today we have some modern perspectives of Vada Vyadhi, the diseases of Vada Vyadhi, which we have seen in the previous classes. Usually, all the neurological disorders, neurodegenerative disorders, and musculoskeletal disorders, including the disorders of tendon, joint, everything will comes under this uh, Vada Vyadhi. Modern perspective of all these diseases can be taken under the concept of Vata Vyadhi, and we can do the treatment accordingly. We will see few of the diseases in the this group of diseases. We will see each one in the following. This will be the diseases dealing in the today's session: spondylosis, osteoarthritis, rheumatoid arthritis, sciatica, tendonitis, epicondylitis, neuralgia, neuropathy, facial nerve palsy, paralysis, and MND. Some important diseases, and these diseases usually come across in our clinical practice also. First, we will move on to the disease spondylosis. Spondylosis, usually, it's a common in our clinical practice. It's very common condition: cervical spondylosis and lumbar spondylosis. Patient will come with a complaint of pain on the back of neck radiating towards the hand, pain on low back radiating towards both legs. Such diseases, such symptoms are very common in our clinical practice in our OPD. So these diseases can be, this spondylosis can be understood in terms of Hridrasi, Vishwaji, or both together, cervical and lumbar spondylosis. If it is there, we can connect with Thalli. We will see spondylosis in detail. It is a degenerative disorder in which the usual general wear and tear occurs and for joints and bones, then as a part of aging, commonly affecting on the cervical and lumbar level, but rarely on thoracic also. Spondylitis is different from spondylosis. Spondylitis is the inflammation of this vertebral area. It can be cervical, thoracic, or in the lumbar level. This inflammation, if it is happening, it can be termed as spondylitis. If it is a wear and tear or degenerative disease, it can be termed as spondylosis. Symptoms will be almost same, but we have the treatment may differ. Inflammatory signs, if it is there, we have to go for a different treatment, and it can be differentiated by nerve, blood test and other radiological investigation. First, we will see the cervical. Because of the movements of neck and the positioning of neck, the activities what we do in regular day-to-day life, this is very prone to degenerative changes. This is very prone to degenerative changes, and neck pain from the spondylosis. Because of spondylosis, neck pain is very common. This pain can spread to shoulder or even down to the arm, towards both hands. It can be spread. Thoracic, next is thoracic. Thoracic, as I told, it is rare, but recently in the clinical practice, if we see the patient who approaches with the pain in the hand or shoulder, if you examine the patient, we can find the tenderness over the thoracic spine. And those tender points, if you apply more pressure, it can be radiating up or down or laterally. So even though it is said to be rare, but in the clinical practice nowadays it is increasing. The prevalence is increasing. But why this is not reported to the clinic? Because this thoracic spondylosis will not present as a difficulty, or the symptoms may not cause any difficulty to the patient. Once we examine the thoracic spine, you can find this problem. After this progression of disease, this can be like the patient can be expressed as kyphosis. It can happen in the thoracic spondylosis. Next is lumbar. It's very common as cervical spondylosis. usually happening in the patients who are using two-wheelers and the road gutter road or this way and this can cause the wear and tear to the lumbar spine, and this is also carrying our body weight, therefore a chance of getting degenerated soon. So as the structure and our activities which promotes the degeneration, which create more chance to get degenerated, lifting weight or walking for a long period or using two-wheeler for a long time, these all activities can cause the degeneration of lumbar spine. So this lumbar degenerative disc can cause lumbar spondylosis. This is the pictorial representation of spondylosis. You can see in the cervical spondylosis that this is the compression. Disc is degenerated disc is compressing the spinal cord, or the nerve root compression will be there. That can cause the pain, radiating type of pain in the shoulder or towards the hands. Second picture shows the lumbar spondylosis. This can happen any level. Even cervical also can happen in the at any level of vertebrae. This usually L3, L4, and L4, L5 usually happening in these areas. Those areas will show symptoms like radiating pain towards the lower limbs. Severe low back pain can also happen in this. This is in MRI also you can find. The second one is MRI picture. First one is a pictorial representation. If this is the this is what exactly we can see in the MRI. This the causes of degeneration or the causes of spondylosis. Main cause is dehydration of disc. Dehydration of disc is due to the degenerative changes, or it can be due to aging, or it can be due to overuse, like as I told earlier. Next one is herniation of disc. Herniated disc. Herniated disc also can compress. The disc herniation, disc is coming out from its own place, and this can compress the nerve root, and bones burst. That calcium deposits on over the or any part of this vertebrae that can compress the nerve root. So it can also lead to the spondylosis. OA, osteoarthritic changes. Osteoarthritis we will discuss later. And in that also degenerative problems can cause compression, spinal stenosis, and aging is one of the major factor. Aging is one of the major factors. Then this dehydration is happening, and it will become thin and hard, and uh, that will lose the cushion effect in between the vertebrae, and that directly will cause the compression of nerve, and that can cause the spondylotic changes. Then repetitive strain injuries is one of the causes that I mentioned earlier. Driving, traveling, and using in front of computer, sitting in awkward positions, abnormally carrying weight, uh, different types of characters of work, that occupation can directly involve in this repetitive stress injuries. And risk factors, of course, for all disease it is there. Familial history should be taken. Occupation is the having a major role in the causative factor of this spondylosis. This weightlifting or walking or driving, etc. And mental health issues, psychological. For almost all disorders, there is a psychological issue in the background. Same as in this spondylosis also. Depression or anxiety disorders can be a precipitating or can be a supporting factor for, or a risk factor for spondylosis. Injury or trauma can cause the spondylotic changes in the either in the cervical, or usually happening in the cervical and lumbar. Symptoms: pain in the neck is the main symptom. If you examine the patient, there will be tenderness, and the tender point, if you give more pressure, that can be radiating towards the hand. Movement of neck will be affected. Movement of neck will be affected. It's a difficulty to move the neck, and if you move the neck, that can cause the pain. If you bend the neck, that can cause the pain. If you bend and press from upward down, that swirling sign elicited, that can cause the severe pain, and that can be a type of radiating pain also. So these are the symptoms. These are the main symptoms, and radiating even to the fingers. That pain can radiate even to the fingers. This depending on the cause or the site of irritation of nerve. And this is the common feature. And some activities or some movements or some positions may flare up the this pain, and it can be time to time it can progress, and neck stiffness will be there. And particularly in some positions, where if you keep some positions head in the particular positions, their neck pain may happen. And sitting also, usually the gents are using purses behind the pants pocket. So for sitting over the purse or sitting on some objects, that can cause some position variation in the position, that can create some shooting type of pain in such in lumbar spondylosis. In cervical spondylosis, the position of neck and movement of neck, and this can be happen. And headache is one of the symptom in seen in cervical spondylosis. This can go unnoticed. This headache can go unnoticed. The patient sometimes come to the doctor and complains of headache. We may not notice the cervical cause. Patient may not complain about the cervical pain on the neck or radiating type of pain. That may be considerably mild than the headache. So patient will highlight the headache. If we missed this diagnosis, if you miss this diagnosis of cervical pathology, the treatment will not be to the apt or to the correct point. So these symptoms should not be neglected. If a patient came with a complaint of numbness of hands or pain in the fingers and the headache or low, usually this headache usually will happen from the back side, back of the head. Headache will start from the back of the head, and such headaches or such pain on the fingers, if a patient complains of, we should elicit the cervical signs, or the examination should be done for the cervical sign to diagnose whether it is cervical spondylosis. Lumbar spondylosis, low back pain, leg pain, low back pain radiating towards the leg. Numbness will be there, cramps will be there, and weakness of lower extremities will be there, and difficulty in walking will be there. And sitting and supine position can relieve. Sitting and supine position can relieve symptoms. Sitting in a normal easy sitting can relieve the pain, because the weight bearing, uh, if your body is bearing weight while standing, so that can create more compression on the lumbar area, that can create more pain, that can increase the pain. So walking and standing position may aggravate the pain, and sitting and supine position, lying position, can reduce the pain in case of lumbar spondylosis. The diagnosis, as all other diseases, physical examination and history taking is very important. Specifically for this, SLR test is there, straight leg raising test, Faber's test is there. Faber's test means flexion, abduction, and external rotation of hip at the same time, and this causes the shooting type of pain in the lumbar area. Ellis test should be done to elicit the site of compression, whether it is spondylosis. To rule out other diseases, you can do Ellis test. Prone position, flex the knee to test the buttocks. Flex the knee to test the buttocks. If it is not possible, having pain, this is positive. Test is positive. And Mennelis test is say similar way. Prone position, press on the sacroiliac joint. The physician or the examiner should press on the sacroiliac joint and lift the thigh with other hand. The patient is in the supine position. Keep one hand on the sacroiliac joint and lift the thigh with the other hand. If the pain is elicited in the sacroiliac joint of the lumbar area, that test is positive. And femoral nerve stress test or femoral nerve tension test can also be done. It's very common. I think everyone knows this test. And next is X-ray, CT, and MRI. X-ray can show some damages with the bone, and bone space reduction in between vertebrae can be noticed or can be elicited from the X-ray. CT can give some more information regarding the bone and joints. MRI is very useful to find the soft tissue problems related with the soft tissue. Nerve compression can be find out where the area of nerve compression, the nerve root compression happening in which area. It can be clearly diagnosed or identified using MRI. Treatment in modern perspective, usually giving an analgesics, NSAIDs, muscle relaxants, steroids, and antidepressants and anti-seizure, anti-epileptic medication. This is the very common practice. We can see from this spondylosis to neuralgia, any kind of pain. These are the common, some of common group of drugs used. Analgesics, NSAIDs, muscle relaxants, steroids. Steroids can be used orally and orally and IV as IV. It can be given. And anti-epileptic drugs and antidepressants can give a relief from pain to an extent. So these are used as add-on therapy, add-on medications in the treatment of such kind of pain, especially spondylosis and neuralgia. Surgery is another choice. Spinal fusion, laminectomy, foraminectomy, intervertebral foraminectomy, discectomy, removal of disc replacement, replacing the disc with artificial disc, and interlaminar implant. These are the surgical measures used to treat spondylosis. These can be the fine last choice if the patient is not responding with any medications, any treatments. The last choice is surgical treatment, because these are having the complications as having all, as for all surgeries there is complications. Similar way, this type of surgery is also having some complications. So physiotherapy or other system medicines like Ayurveda or any other traditional system of medicines or any other system of medicine can, if they can give some relief from the pain, need not to go for surgery. And next disease is osteoarthritis. Osteoarthritis is also a common disease, very common disease, which degeneration of it. It's also a degenerative disorder. It is also a degenerative disorder affecting the joints, usually affecting in the weight-bearing joints. So in Ayurveda, in Vadavedi, we have seen that Sandigada Vada, Sandigadavada, Vada Purna Drisparsa, Shobha, Sandigade. Shobha is there, Vada Purna Drisparsa Shobha is there, Prasarana Agunjino Pravritista Vedana, movement is affected. This all can be seen in the disease osteoarthritis. It's a chronic condition, degenerative disorder characterized by breakdown of the joint cartilage, which cause the bone to rub against each other. This joint space reduction happening, and in the last stage, fourth grade, it will be rubbing. The bonds will be rubbing together, and stiffness, pain, and loss of movement of the joint is the cardinal features. Main feature is pain, stiffness, and loss of movement of the joint. The joint functioning will be getting affected. Next, the causes of osteoarthritis. Causes of usually, as I told, it's directly related with aging. Directly related with aging process. Aging can cause degeneration. That degeneration can cause the joint degeneration, and that joint degeneration will lead to OA. And overuse of any joints, that can also cause the OA. Overuse of joint, walking for very long, climbing the step very abnormally, so very long climbing steps very regularly or daily climbing the steps. And this can also overuse of joints. This type of overuse can cause the dependent joints. And unusual postures. following some unusual postures for a long period of time, that can also cause the problem with the particular joint, and osteoarthritis of that joint will be happening. Idiopathic is unknown. Unknown causes are there. It can be localized causes or generalized. We don't know. We cannot identify the reason of this diagnosed OA. That can be considered as idiopathic. And secondary causes are there. Trauma. If a person had a fall or injury in his childhood, say it is happening in the age of 15 or 16, he might have treated at the same time, and that's hit on the right knee. Suppose it is the hit on the right knee happened, and he treated some with some analgesics or something, and completely he got completely relief. He got a complete relief, and later on, after 15-20 years of his after 15-20 years, at his age of 30 or 40, the the normal aging process will happen. Thereby, a degenerative change will occur. Later, at that time, this joint, the previously affected joint, will be getting more prone to the degenerative disorder, that is osteoarthritis. So another joints may not get affected, but this joint may get affected because this is previously injured. This trauma can cause osteoarthritis continuously with the trauma, in continuation with trauma, or in later stages. If it is in a childhood or young age, that may not happen at that time, but it can happen later. In Ayurveda, we can connect as Havaigunya Pradesha. That is, once Srodo Dushti Pradesha is there, any dosha dushti, any visheshna of dosha, any nidana can cause visheshna of dosha. That visheshan will affect in the Havaigunya Pradesha. Havaigunya Pradesha is previously affected Pradesha. So this is the pathology happening in the osteoarthritis. And congenital can be there, developmental disorders can be there, metabolic and endocrine disorders. Metabolic disorder, hyperthyroidism, it can be there. In hypothyroidism, with medication, degenerative changes can happen. Endocrine disorders will be, metabolic disorders like diabetes or dyslipidemia. Even in this medication for this kind of disorders, the medication for this kind of metabolic disorders can also cause a degenerative pathology in the bone and joints. Other bone and joint disorders, any pathological condition or infectious condition, already treated with the conventional methods or antibiotics or some medications. If it has treated, and later that joint can get affected with this kind of degenerative disorder like osteoarthritis, and many other causes also there. These are the some common and major causes explained here. Clinical features. It can cause pain into the knee, especially in weight-bearing joints are mostly affected. Knee, hip, and shoulder can be affected. Distal interphalangeal joints, cervical spine, and lumbar spine also can be affected. Osteophytes in the distal interphalangeal joints can be seen like Heberden's node. This is the Heberden's node. This is happening in the degenerative disorder like osteoarthritis. Vague pain and stiffness of the knee, especially getting up from the sitting position. After a resting position, getting up, moving, or walking, or standing from sitting position, this can cause the vague pain and stiffness. And experience disability while walking downstairs or slope. Walking down or walking down the downstairs, the patient may feel difficulty in walking. And one of the main sign we can elicit is crepitus. If it is a degenerative condition and there is no much inflammatory changes in that joint, we can elicit definitely crepitus, especially in the knee joint. And lumbar pain can be affected, low back ache, and it can cause sciatica. Sciatica will be coming in the following slides, and this can also can cause the sciatica. This osteoarthritic or degenerative joints can cause spondylosis, sciatica, other neurological pain, etc. So this can also be a cause for other diseases. Then the pain usually worsens by the activities, and it will be uh, reduced, subsiding with the rest. Usually, weight bearing activities can aggravate the symptom. The patient might have noted while he was carrying a weight or he was doing a heavy job. He will explain that I had the pain or I started the pain when I lifted this or when I climbed step for unusually climbed step for 3 stairs like that. If such situations can aggravate the pain, and that might be the first symptom noted in the osteoarthritis. So after getting a rest for a long time, the pain will subside. After getting rest, pain will subside once he started walking or started doing activities of particular joint. That pain will aggravate. This is the clinical feature in osteoarthritis. This I told already, Heberden's notes. And diagnosis. How can we diagnose? Laboratory investigations like common investigations we should perform CBC, ESR, CRP, RF should be done to for a differential diagnosis, and to rule out the infections or any other arthritis condition. And synovial fluid examinations are there. Very common examination is X-ray, imaging technique, X-ray. In X-ray, there will be evident narrowing of space. Subchondral sclerosis will be there. Osteophyte formations may be there. Subchondral bone cyst can be seen. There is the scale to measure the degree of degeneration in osteoarthritis using the X-ray. That is Kellgren's scale. Kellgren's Lawrence scale is having 4 grades, and in that these points are included: narrowing of joint space, subchondral sclerosis, osteophyte formation, and other deformities, other cyst and other deformities are included. These points are included, and grading is there. So in a mild change or very mild osteoarthritic change, Kellgren's Lawrence scale grade 1. So in X-ray, it shows that very mild narrowing of space, and that is a suspected narrowing space, not a evident narrowing or not an evident narrowing. There is space reduction is suspected. That is grade 1. Second grade, Kellgren Lawrence scale second grade, if we can space reduction is evident, and some subchondral sclerotic changes are observed. In grade 3, very evident space reduction and subchondral sclerotic changes and osteophyte formation will be there. And in grade 4, there is no space in between the joints. So these are the grading of X-rays using Kellgren Lawrence scale. This is very commonly used in the clinical practice. And MRI and CT can be done. As I told earlier, MRI can give information about the soft tissue damages, soft tissue injuries and soft tissue damage surrounding the joint. CT will give more evidence regarding the bone and joint. Treatment, as I told earlier, this is pain relievers. To relieve pain and inflammation, paracetamol or any NSAIDs can be used. Reduction of body weight is one of the major aim of treatment. Reduction of body weight. Weight-bearing joints can be weight-bearing joint. In the weight-bearing joints, pain can aggravate if the weight is more. So weight reduction is one of the major aim of treatment in osteoarthritis. And another aim is management of metabolic and endocrine disorders, if any. As I told, metabolic disorders and endocrine disorders can cause degeneration. Even the medication can cause degeneration. So a proper management of metabolic and endocrine disorder can give a supportive therapy in the management of osteoarthritis. In diabetes or even hypothyroidism, if we are supplying thyroid hormone or insulin, if it is in a large quantity than the required quantity, that can lead to a degeneration. The metabolism, hypermetabolism will happen, and that can lead to the degeneration. So proper food supplement, proper nourishment, nutrition are very important. If the especially if the patient is having metabolic and endocrine disorders. And intra-articular corticosteroids, injection intra-articular corticosteroids, usually commonly in the practice, we might have seen the patients. They will come to us and they say, I have this knee joint pain since 1 or 2 years. I had a severe pain last or 2 months back, and I had taken an injection inside the joint. I had taken injection inside the joint, and there was no pain for this last 2 3 months. But now I'm having such pain. I don't want to go for an injection. Any other alternative solutions are there? These are very commonly seen in our clinical practice. Patients are coming and saying these kind of things. And interleukin inhibitors are also used. Interleukin inhibitors are helping to reduce the inflammation and thereby reducing the pain. Surgical treatment, and this is a very recently popularized treatment, joint replacement therapy. And it was uncommon earlier, but it is common nowadays, and every hospital having the setup or the facility for joint replacement. And this osteoarthritis, they have, if the choice, modern medicine medical system has the choice of no knee replacement if the disease is not responding to NSAIDs or any other pain relieving measures or any other medical management. So if medical methods fail, you can go with the replacement surgery, mainly knee replacement, and also hip replacement therapy is available, and other joint replacements also available, but it is very rare. Next, we will move on to the disease rheumatoid arthritis (RA). This is very common, very popular in among the public. Even non-medical people are very much aware of this rheumatoid arthritis, and the patient may come to us by after learning about the disease. They are affected with the disease. They might have knowledge than us in this particular condition or the disease for such in that person, because rheumatoid arthritis is a disease in which multiple systems are affected, and the symptoms may vary depending on the system affected. Not only joint pain, there may be association of different systems, and symptoms may vary very widely. Very wide range of symptoms may be there. So we might have a knowledge about rheumatoid arthritis and some common features, and some uncommon features might have noted by the patient himself, and he will be having the knowledge, and he will express as his own symptoms, and he says as he is the authority of rheumatoid arthritis. That much common this disease is, and very aware. People are very aware about this. And while coming to the Ayurvedic understanding or Ayurvedic aspect, we can consider this rheumatoid arthritis in two aspects. It can be either Amavata or Vatarakta. Depending on the symptoms or depending upon the patient, it can vary. All rheumatoid arthritis cannot be correlated as Amavata, or all rheumatoid arthritis can be correlated as Vatarakta. Some state-based and thought-based, college-based, some different thoughts are there. Rheumatoid arthritis. Some scholars say rheumatoid arthritis is Amavata. Some scholars say rheumatoid arthritis is Vatarakta. Better we need not to stick on rheumatoid arthritis is equal to Amavata, or rheumatoid arthritis is equal to Vatarakta. Very commonly these two conditions are there relating with rheumatoid arthritis. And this rheumatoid arthritis can express as Amavada, Pravritta Amavada, or it can express as Gambhira Vadarakta. Patient to patient, symptom may vary, patient to patient, disease pathology may vary. So, you have to diagnose, tailored approach should be there. We have to diagnose a patient whether it is Amavata or Vadarakta. Then you have to treat the patient. Otherwise, there is a chance of failure in treatment. If you always think rheumatoid arthritis is Amavada, sometimes the patient, some patients may express the symptoms of Vadarakta, and if you give the treatment of Amavata, that can aggravate Vadarakta, and vice versa. So, these two diseases should be in mind, and it should be in consideration while treating a patient of rheumatoid arthritis. Rheumatoid arthritis, as I told, is a chronic multi-system disease of unknown etiology. Etiology is still unknown. Some theories are there that will be explaining, that will be mentioning later, and characterized by persistent inflammatory synovitis. Persistent inflammatory synovitis, usually involving the peripheral joints symmetrically. This is the main point. Symmetrical involvement will be there in RA. Joint, if the right hand is affected and the left hand also might be affected. Very usually, this symmetrical involvement is there. Can be very rarely, it can be unilateral, but very commonly involving the peripheral joints and symmetrical. Hence, peripheral joints rather than the weight bearing or major joint. Peripheral joints are affected and joint involvement is symmetrical. Although cartilaginous destruction will be there, bony erosions will be there, and joint deformity are the hallmarks. The course of RA can be quite variable. As I told, once it starts as some disease or some symptoms in the hands or interphalangeal joints, symmetrical involvement of uh, minor joint, and later on progress, it can affect any other systems, and we cannot predict the course of RA in general. It can vary from person to person, and we should follow a person of RA throughout the course of treatment or throughout the disease, because it is not curable. It's not a curable disease. It can be manageable. Can be managed. Manageable, and the quality of life can be improved. So we should follow the patient, and wherever the symptoms changing or systemic involvements are changing, we need to understand, we need to tackle that situations and handle accordingly. Causes in association with HLA, this is genetic cause. Both genetic and environmental factors play a role in initiating the disease. There can be a chance, as I told, there can be, previously I told, there is Hawaii Gunya. So, if a person probably susceptible for disease, he may not get disease because of his lifestyle. And another person, very less prone to the disease, can get affected with the disease very easily because of his unhealthy diet and habits, regimens. So, this is directly related with the environmental and lifestyle pattern. There can be a susceptibility, there can be the patient may be prone to the disease but may not get affected if it is a health, if he is following a healthy lifestyle. And if he is not following a healthy lifestyle, even not prone or very less chance to get disease, he may get affected because of his wrong lifestyle. Immunological reaction, hyperimmune reactions will be there in RA. So immunosuppressants, immunomodulators are giving. foreign antigen preferentially focused on synovial tissue. Any foreign antigen in the synovial tissue can cause this, and inflammatory reaction in the joints and tendon sheath. These can be the causes. Cause in the sense this can be a triggering factor. Cause is unknown, and there may be the patient may be susceptible for a disease, and these causes can trigger the disease. And rheumatoid factor, the RA factor greater than 14 IU per ml in the blood serum, this can also cause the disease. This can be a cause and this can be a diagnostic finding. And even RA factor is negative, there is arthritis. It is called as seronegative arthritis. RA factor is negative, but patient is patient is presenting with the symptoms of arthritis. And inflammatory process can cause the disease. Articular cartilage destruction, any cause of destruction, that can be infection or trauma or any damage, any kind of cartilaginous destruction can trigger the rheumatoid arthritis. Clinical manifestation. This is becoming a common disease. 0.5 to 1% of population. Prevalence is 0.5 to 1% of population. Women are getting affected 3 times than men. Women are getting affected 3 times than men. We don't know the reasons. Maybe the tender or weak body nature or something. But it is like that. In Ayurveda, in Vadarakta, it is mentioned that Prayana Sukumaranam Achakramana Silina. Prayana Sukumaranam Achakramana Silina. Sukumara, women by nature itself is Sukumara. So that can be a cause of getting rheumatoid arthritis. The prevalence is 3 times more than in men. And this prevalence increases with the age. Onset most frequent in the 4th and 5th decade. After the age of 40, after the age of 40 or 50, this the onset, this manifestation will happen. Whatever the previous activities or previous regimens or food that reflects after the age of previously, even in the young age or healthy age, that will reflect after the age of 40 or 50 as rheumatoid arthritis or any other autoimmune disorders. Autoimmune disorder, as I told earlier, there is a chance of the chance of getting disease is there in the body or in the person, but the activities, food activities, regimen, etc., ahara and vihara will decide whether the person should get affected or not. So onset is after the age of 4th decade or 40 or 50 age, but the reason may be the nidana may be in the previous stage. Articular manifestations are there. Articular manifestations typically symmetrical polyarthritis. Arthritis involving more than 3 joints or more than 2 joints is called as polyarthritis. Symmetrical manifestation of articular pain will be there. Peripheral joints are affected. Tenderness will be there. If you just touch or squeeze the joints, there will be severe pain. Swelling will be there in the affected joint. Morning stiffness is common. We can ask for the patient to diagnose RA, even seronegative arthritis. We can ask whether the pain is increased during the morning time after getting up from the bed. In osteoarthritis, the pain aggravates after a work or heavy weightlifting or walking or some work. Joint movements, joint is active after the activity of joint, the pain aggravates. But in rheumatoid arthritis, after resting day, after long time of rest, after sleep, getting up from the bed, the patient will have the stiffness and pain in the especially in the small joints. TAP and MCP joints are frequently involved. Interphalangeal joints and metacarpophalangeal joints are very commonly involved. Joint deformities may develop after persistent inflammation. not in the beginning. The nature of disease, the articular manifestations will be there in a patient in the beginning. Very mild symptoms will be there, and that symptoms can subside with some medication, some pain relieving medication, or it can subside by itself. Later on it will recur, frequently recurring, and say not treated properly. This can lead to joint deformities. This persistent inflammation can cause joint deformity in later stages. Extra articular manifestation. That's what I told earlier. This rheumatoid arthritis will not limit in the joints. It extra articular manifestations are there. Cutaneous rheumatoid nodules are there. Vasculitis, skin and vascular changes will be there. Pulmonary, very importantly, pulmonary ILD can cause ILD. Bronchiolitis, that BOOP, bronchiolitis obliterans organizing pneumonia. This is a it is even though it's very rare, but it can occur in the patients with rheumatoid arthritis. Pleural disease, it will be there. Kaplan syndrome or rheumatoid pneumoconiosis is the another symptom. It's a pulmonary symptom. Even happening in negative RA, but seropositive RA pneumoconiosis is associated. If it is associated, we can diagnose it as rheumatoid pneumoconiosis, and these pulmonary symptoms are there. And ocular symptoms, keratoconjunctivitis, Zika, episcleritis, and scleritis will be there. So it is, as I told, it is not limiting. This rheumatoid arthritis is not limiting in the joints or articular parts. It exceeds in other systems also, like this. Ocular symptoms also can be there. These are the deformities. Ulnar deviation in the first picture, you can see ulnar deviation. Is that the thumb or the thumb? This is not there in the picture. The thumb will be in the shape of Z, and muscle wasting will be there, especially thenar and hypothenar wasting can be seen. Buttonar deformity is there. It can be in the third picture, last down picture. It is there, the buttonar deformity, and second in that picture, the second one is swan neck deformity. These are the deformities very commonly seen in RA. We can definitely elicit in the patient. These deformities will be there, but in the progressed stage of RA, not in the beginning. In the beginning, there will be some articular changes will be there. The morning stiffness will be there. Small joint pain will be there. Inflammatory signs will be there. These will be these mild symptoms will be presenting in the first stage of RA. If it is not treated properly, this can lead to this kind of deformities very fast. Even if you treat also, it can cause with some deformities, but very later. We can we can give support to the patient for a long time without any deformities with a proper Ayurvedic management. This hematological, as I previous, this in continuation with extra articular manifestation, hematological symptoms like anemia will be there. Felty syndrome. Felty syndrome is not a common disease, but it can be. I have seen 2 patients with this Felty syndrome in this throughout my 11-12 years of practice. Only 2 patients I have seen. The main feature, these 3 should be there: RA, splenomegaly, and neutropenia. These 3 features will be seen together in this patient. RA will be there, splenomegaly will be there, neutropenia will be there. And cardiac symptoms, pericarditis and myocarditis. Pericarditis and myocarditis can be seen in RA. So we should take care of the heart, health of heart also for a patient with rheumatoid arthritis. Usually a rheumatologist will give a regular yearly or half yearly checkup for a rheumatoid arthritis. They will give treatment, NSAIDs or DMARDs are there. This is modifying anti-rheumatic drugs. We will see later. Even whatever the medication, if the patient is under whatever the medication, NSAIDs or DMARDs, the modern physician, modern medical practitioner will definitely go with a health checkup once in a year or twice in a year, depending on the severity of disease. So this is to avoid the complications or extra articular manifestations of rheumatoid arthritis in any course of this disease. So cardiac pericarditis and myocarditis are also can be as a extra articular manifestation of rheumatoid arthritis, and neurologic manifestations like myopathy secondary to cervical spine disease, entrapment, vasculitis. This vasculitis I mentioned earlier also. These neurological symptoms can be seen. How we should diagnose next? How to diagnose a RA patient, or how to diagnose rheumatoid arthritis? Mainly, as any other disease, mainly clinic history, physical examination, careful examination of all joints. We should not omit any of the joints. We should give all the joint examinations, and all system examinations should be done in a patient of RA. A very clear, a detailed history should be taken, because, as I told, this can be started in very early stages. Very early stages means years back, to 5 or 6 years back, it might have started, and patient might have taken over to counter any anti-inflammatory medicines, and that might have subsided. And this frequently, or once in a year or twice in a year, this happened frequently, and patient was under self-medication or with no medication. Later, the disease might have progressed, and the patient approached the doctor. Once the patient approached the doctor, or meeting the doctor, we may be we should not think that this is the patient is coming first time, and we should not think this is a acute, or this is very newly onset disease. We should clearly go for the history, and thereby we can find the chronicity of disease. We should ask the questions: when it started, when the symptoms started, and how it was, and how frequently it was, and how he managed it. Very importantly, in the history taking of rheumatoid arthritis. And second very important factor is rheumatoid factor, RF or RAF. This will be present, positively present, above 14 IU per ml will be present in the in more than 66% of the total patients. More than 66% will have the serum positive with rheumatoid factor. Other 34%, less than 34%, may be having seronegative arthritis. Seronegative rheumatoid arthritis. Seropositive is RA factor positive in the blood. Seronegative arthritis symptoms are there, but their blood test shows the uh, serum negative. That is, blood test show negative for rheumatoid factor, and there will be extra articular features also will be present. And other laboratory data should be collected, CBC, SRCRP, for finding the inflammation or other infections. Any other severity, to assess the severity of disease, we need to go for this test. And synovial fluid analysis can be done. This is helpful to rule out the crystalline arthropathy. Crystal deposit of crystals are there, can be found in the joints. So crystalline arthropathy can be ruled out by analysis, fluid analysis, and infections can be ruled out, or can be identified by the synovial fluid analysis. So this to be done in a patient suspected with RA. Anti-CCP antibody, it's more sensitive or more reliable than rheumatoid factor. This is nowadays we use anti-CCP antibody in the RA patients to diagnose it, rather than using the rheumatoid factor. It's very reliable, and we can go with it. Costlier than rheumatoid factor, but very reliable, and very useful to detect early stages of rheumatoid arthritis. And radio investigations like X-ray and all can be done to find the juxta-articular osteopenia. Juxta-articular means Juxta means near to. Articular means joint. Juxta articular means near to joint. Osteopenia. Osteopenia is the density, the reducing the density of bone, or it also a sign of degeneration, joint space narrowing, marginal erosion. This can be find out using radiographs, X-ray, MRI can be done to find out the condition of joints and around the tissues or parts surrounding the joints. And marginal erosions also can be detected by using this radiological technique. Management, modern science says there is no permanent cure, only supportive or palliative treatment is there for RA. But in Ayurvedic treatments, if it is detected earlier, the patient can live without symptoms, but may require after a long time. Symptoms may recur and patient may require more treatment. So we can consider it as having no cure, but very effectively we can manage Ayurvedic measures. Modern treatment measures aim are to lessen the pain, to reduce the pain, to reduce the inflammation, to improve or maintain the function or function of affected joints or affected parts, prevent long-term joint damage. As I told earlier, if it is not treated properly, inflammation is not treated at the right time, it can cause deformities. It can lead to the deformities in the future. Control of systemic involvement, and that is what I told. Frequently, modern physicians will check frequently the other system parameters like renal function, kidney function, thyroid, metabolic disorders. All will be regularly done checkup for to uh, to take care of in a systemic involvement, or to diagnose earlier if any systemic involvement is there. So we can also go with a regular checkup for a rheumatoid arthritis patient to find out whether there is any systemic involvement. And patient education of diseases is very important. Some doctors, some physicians say first visit, they will say the patient that this is not a curable disease. The patient may ask, doctor, how long I should take this medicine, how long I have to take medicine. I have an experience with the patient, and that patient had taken treatment from another system of medicine, and she came to Ayurvedic system, and she asked whether any alternative solution is there for this disease. I told some supportive therapy we can do, because it became a very chronic. And I asked why you are not following the previous system of medicine, and she told, when I asked the doctor, how long I